Good afternoon, I'm Mr. Andy. We're going to go over the pre-hospital cardiac trauma demo. So first things first, we've got gear here as needed. The instructor is going to evaluate me as if I were a student. She will start off by giving me the scenario.
You get called to report to the scene for one flight deck casualty after the arresting gear wire has snapped.
Okay, so BSI from my buddy and I, is my scene safe?
Scene is safe.
Okay, mechanism of injury, sounds like we have a wire snap. Number of patients is hopefully 1.
Yes.
I'll have additional help on standby, and I'll decide to take C-spine precautions because he probably could have fell after that. So, general impression, what do I see here and smell?
You see one patient lying on the ground, bright red blood spurting from his right amputation, and he's screaming for help.
Okay, so based upon this general impression, I have a very obvious life threat. I can assume the airway's open, so that's not the priority. I can assume he's alert, but I don't know his level of consciousness. Let's go ahead and address that life threat. Grabbing our tourniquet, let's go and identify the injury. Is the injury right here at the right amputation?
Yes.
Okay, so we're going to apply pressure proximal of the wound right into the inguinal area right here. So put your entire shin into the inguinal area. Let's grab our tourniquets, and we're going to put the nylon side of the tourniquet to the patient's skin. You can shimmy this under if you'd like. You can lift the leg up if you'd like for right now. And I'm going to lift this leg up so that we can better see the technique. So when you have the tourniquet on here, put it through the loop, hold the red end, hold the windlass rod, hold them too tight, and make sure you have full contact of the Velcro area. As you can see on the posterior end of the wound here, you're going to be about 2 to 4 inches away from the posterior of the open amputation. Or you can assume high and tight. I'll let the instructors decide on that. So as I'm looking at the wound, I'm going to turn the windlass rod while I'm looking at the wound until the bleeding stops. Once the bleeding has stopped, reassess and make sure that the bleeding has stopped. Your instructor will come up. They will try to pull the tourniquet off as appropriate. Once we determine that the bleeding has stopped, we'll mark the tourniquet time. You can mark it on the leg, on the label here, or very commonly on the patient's forehead. All right, so we have applied direct pressure, we've put on the tourniquet, we have marked the tourniquet time, we've reassessed. Has the bleeding stopped?
Yes.
Okay, so let's go back to the beginning and do the rest of our primary assessment. So, hey, I'm Mr. Andy from EMS. Can I help you?
He screams for help.
Okay, so hey, what's your name? Where are you? What time is it?
Patient responds appropriately.
Okay, to all 3?
Yes.
Okay, so now I can say that the patient is alert and oriented times 3. Let's go to airway. So airway, he was talking to me, he was screaming. I can medically assume that his airway is open. I do not have to clear it, but I can secure it. So you can verbalize that you'll grab an NPA and apply the NPA as appropriate. Let's go to breathing. Breathing, we must show that you must expose the chest and physically look for any injuries. Any injuries noted?
None noted.
Let's palpate for injuries. So tiger across the chest here, tiger claw across the chest. Any injuries noted?
None noted.
Look, listen, and feel as appropriate for the rate and quality of the breathing. Anything noted?
Rapid breathing.
With rapid breathing, we should recognize respiratory distress. Let's respond to that appropriately. Grab your O2 tank. This will be pre-assembled. So, O2 tank, there will be 3 things you must do to give appropriate O2. 1, turn on the tank, lefty-loosey. 2, turn it to 15 liters per minute. Put your tank down. Number 3 is putting a finger over that NRB one-way valve, so therefore your bag will inflate. Is the bag inflated?
Bag is inflated.
Let's go ahead and apply this. All right, so breathing is now complete. Let's go ahead and do circulation in no particular order. We're going to check radial pulses. Please look at the thumbs, fingers on the thumb sides of the wrist. Radial pulses are?
Weak and thready.
Weak and thready pulses. So, skin's color, temperature, condition?
Cool, pale, diaphoretic.
Okay, let's do a blood sweep. So big pipes as in the carotids. Look at your hands. Any bleeding?
No blood.
Let's go to the femorals. I have probably some obvious minor bleeds at the stump, but any other life-threatening bleeds?
No major bleeds.
Your leg?
No life-threatening bleeds.
Let's go to the brachials.
No blood. No blood.
All right, so we do recognize this patient is in shock, so let's take care of that. 3 things that you must do to treat for shock, and 2 of them are already taken care of. So Lay them into supine, give them the O2 as appropriate, and let's prevent hypothermia. So grab your blanket. Let's go ahead and put the shiny side, the reflective side, over the patient. Make sure that the patient is completely covered as appropriate. And state that this patient is a high priority transport, meaning that we will do the primary assessment on the scene, no more than 10 minutes. We'll be back in the ambulance, driving off to the hospital, in particular for this guy, the operating room, and we will do the rest of the secondary assessment in the back of the ambulance. So ask the instructor if you can take this off. May I take this off?
Yes.
And let's continue the secondary assessment. All right, so grab your pen light if you have one. If you don't, just ask the instructor for one. Okay, so I'm going to tell my instructors what I'm looking for. I'm going to show my instructors what I'm palpating for and auscultating. So, for example, I'm going to look from head to toe for decap BTLS. Do I see anything?
No.
All right, so then I'm going to palpate as appropriate at the head. I'm going to use my fingers or my palms, depending on your instructors. I'm going to palpate for any tenderness, instability, crepitus. So, as I palpate, I'm pushing on bony structures, noting any tenderness, instability, crepitus. Anything noted?
None noted.
Nothing to auscultate at the head, but there are some specific things that we should look for. So let's look at the eyes for pearl or raccoon eyes. Anything noted?
None noted.
Let's look into ears. You must look at both sides of the head to get proper credit. So looking at the ears here and behind the ears for Battle's sign and cerebral spinal fluid and blood. Anything noted?
None noted.
Any CSF or blood in the nose?
None noted.
Looking at the mouth for lobes. Anything noted?
Clear.
Okay. If this slides off, you can just put it back on, not a big deal. All right, so let's go to the neck. We're looking for JVD, tracheal deviation. Anything noted?
None noted.
All right, we've already said decap BTLS, so we're not going to say that again. Let's palpate the back of the neck. I'm taking my fingers and I'm going to drum up and down the spinous processes of the cervical here. Anything noted?
None noted.
Okay, so again, nothing to auscultate at the, this lump's falling off. At the neck, let's go ahead and go to the chest. Let's push on the clavicle bones, sternum, rib cage. Anything noted?
Intact.
Okay, can we listen to the lungs? Yes, we can. So let's grab your stethoscope. If we don't have a stethoscope, ask the instructor for one, or at least show the instructor where the 4 areas that the stethoscope would go. So those 4 areas would be the 2 apexes and the 2 bases, being mid-clavicular line, the middle of the clavicle bone, about an inch underneath this clavicle bone. You would put your stethoscope right here and listen, and she'll tell you, or they'll tell you what the result is. So as I'm listening here, I find lung sounds are
Clear to auscultation.
okay.
Clear to auscultation.
Now, the base of the lung, we're going to find it's that same mid-clavicular line, just underneath the pectoral muscle. So again,
Clear auscultation. Clear.
okay, good deal. So now let's go to the abdomen. We have inspected, palpated, and auscultated the chest. Let's go to the abdomen. Divide the abdomen into 4 distinctive quadrants. We'll use the belly button as a landmark. I want you to note that a lot of times people tend to go a little bit too low from the belly button. So this right here, using my fingertips, as I'm rolling into my fingertips here, my fingertips are touching the left upper quadrant, left lower quadrant, right upper quadrant, right lower quadrant. So again, patients left and right, left upper, left lower, right upper, right lower. I am palpating for turd P. Anything noted?
None noted.
Okay, so let's go to the pelvis now. Pelvis specifically, we're going to look for buds. Anything noted?
None noted.
Now, the iliac crest is located where the screw marks are right here. We want to push on the bony prominence of that iliac crest. So palms on that iliac crest, push into the patient, push medially into the patient. Any tenderness, instability, crepitus?
None noted.
Okay, let's go to the legs. Thankfully, when we do the legs, it will mirror what we will do to the arms. So we've already looked for decap BTLS. Let's palpate as in a twisting motion up and down the legs. I don't necessarily need to touch this leg. I can already see the gross injury present. So let's palpate for our CSMs, as in circulation, sensory, and motor function. So dorsalis pedis is going to be high up on the metatarsals here, the first and second metatarsal, right between in that intercostal space. What's my pulse like?
Weak and thready.
Okay, so I have a weak and thready pulse. For sensory, I want to grab a toe, preferably his big toe. Just grab his toe and ask him, hey, what toe am I grabbing?
He responds appropriately.
Okay, then ask him, hey, can you wiggle?
He wiggles.
All right, so we have a pulse, he does have sensory, and motor functions. Normally we would continue that here, but as appropriate, we'll relocate ourselves to the arms. All right, palpating the arms. I like to do both sides first. I like to check CSMs on both sides at the same time here. So, pulses,
Weak and thready.
grab the thumbs. Hey, what finger am I grabbing?
Responds appropriately.
Can you wiggle?
Wiggle.
If there's any disparity or any differences between the two, that is the best and most efficient way to evaluate the patient. So, we have done the anterior space. Let's go ahead and roll the patient over to the posterior. Keep in mind that when we roll the patient, we always want to roll the patient towards us, never away from us, and we always want to roll the patient off of the injured side. So, let's get to this side. I'm going to lift this arm up so I can get closer to the body. You will learn some more specifics on how to roll a patient with C-spine precautions, but for general purposes right now, I'm going to put a hand on the pelvis, hand on the shoulder. 1, 2, 3. We're going to pull the patient up. If you have difficulty, just take your time and be careful not to hurt yourself. Looking up and down the spine here, I'm looking for decap, BTLS, anything noted?
None noted.
I'm going to push up and down on the cervical, thoracic, lumbar spines. Anything noted?
None noted.
I'm going to tiger claw up and down. Anything noted?
None noted.
Finally, I'm looking for butt. Anything noted?
None noted.
Good deal. So, on my headbands count, 1, 2, 3, we'll put the patient back on the board as appropriate. And again, in musculoskeletal, you will learn the details of how to perform that. So, we're going to take a set of vital signs. Tell your instructor you will do that. They'll tell you the vital signs you get as appropriate. This time, we're going to take care of any secondary injuries that the instructor has told you. In this particular case, if there's no other secondary injuries noted, we will take care of the stump. So, grab your dressing. Now, make sure that when you have your dressing, the moment that you open a package dressing up, you're going to have the white part available. This white part is the dressing. The rest of this is the bandage. So let's come up over here. You can lift the leg up. That's going to be perfectly fine and support it. There are only 2 things that we're going to evaluate with this dressing of the stump. To get max 2 points, you have to, 1, make sure the dressing actually goes on the open wound. Number 2, you have to apply adequate downward pressure. We want downward pressure into this stump. So, there are a number of ways to do this. I'm just going to show you the way that I've been doing it. Doesn't necessarily mean you have to do it this way. So again, white on here. I'm going to hold pressure right here. And I like to turn this roll so that I can roll this against the patient's leg. Once I make my first rotation here, I'll have a good bite on the base of the wound. Once I have a good bite on the base of the wound wrapped here, I can start going over the wound. A lot of times, students will put a lot of the dressing at the base of the wound, and you won't have enough dressing to wrap the rest of the wound. So let's make sure we put enough downward pressure. Now, also you want to make sure that you're pulling the elastic portion of the bandage here to apply that pressure. Now, once you get to the end here, you're going to notice that the Velcro side is upwards. We can just twist this around and apply the Velcro to secure the dressing as needed. In a real life scenario, I would use 3 silk tape or any other device as needed to secure the dressing. So the stump is taken care of. All right. The rest of this lab is now going to be verbalized. So what you will have to verbalize is the patient is unstable, meaning that we will reassess him every 5 minutes. If he's stable, we'll reassess him every 15 minutes. What it means to be stable will change upon what parameters you're going to use and where you are. So tell me the 4 parts of your reassessment. Those 4 parts being the vital signs, the interventions, the primary and secondary assessments. So every 5 minutes, you're going to redo vital signs, interventions, primary and secondary assessments. If you have an intervention, that is a medication, in this particular case being the O2. Because it's a medication, I will want to reassess the effectiveness of that medication after 2 minutes. So how do I know if the O2 is working for my patient? I should probably check his vital signs. In this particular case, it will be the respiratory rate and the pulse ox, the SpO2. Finally, go ahead and tell your instructor you will give a missed report, which means I will talk about the mechanism of injury, the injury itself, any signs and symptoms, the treatments I have given, and I am done.